Okay, Chapter 9, Holistic Management of Patient with Wounds. In this chapter, we're going to talk some more about nutrition and about all of the different pieces of healing related to nutrition. The objectives are to describe the role water, protein, carbohydrates, fats, vitamins, and minerals play in wound healing, describe the components of a nutritional screening for patients with open wounds, interpret laboratory results used to assess nutritional status, and identify potential barriers and methods to facilitate patient adherence. So we start by talking about the importance of nutrition and wound healing. We're going to break it down into specifics such as water, protein, carbohydrates, fats, vitamins, and minerals, and how each of these nutrients are required for, first of all, to maintain a homeostasis. So if you have a beefy red wound, you have to have nutrition for that wound to stay beefy red and to continue to go through the phases of healing, so to repair and to regenerate. Here's the nutrients again that we're talking about: water, protein, carbohydrates, fats, vitamins, and minerals. First of all, we're going to talk about water. Water is vital to wound healing. We've talked a lot about how a loss of skin, a loss of the epidermis can cause a increase in dehydration, such as in burns. So dehydration is defined as 1% decrease in body weight due to fluid loss. So it leads us to the fact that we need between 30 and 35 milliliters of water per kilogram of body weight a day. For most of us, that's about 2.7 to 3.7 liters per day. When you're talking about someone who's in a facility, a nursing home, a hospital, and can't get their own water, that's significant because they're generally not going to get this much water. People with large wounds or burns need even more water, again, because there's more fluid loss with the open wound or the burn. Patients on the air fluidized beds, so the beds that have the air running through the bottom of them to keep the person from having pressure points, those people require 40 to 60 milliliters of water per kilogram of body weight daily. That much more because of the air running through the bottom of this bed increases the fluid loss. So you want to get a dietitian referral if you have a patient that has swallowing difficulties. A lot of times, because of a stroke or a head injury, a patient can have difficulty swallowing. Also a patient who's on fluid restrictions, like someone who has COPD, may be on fluid restrictions. Or if a patient's MPO or has nothing by mouth for more than a few days, you want to make sure there's a dietitian referral because there needs to be a replacement. There needs to be you need to address the fact that they're not getting the amount of fluids they need. Protein is required for collagen synthesis, granulation tissue formation, angiogenesis, remodeling, and immune function. A deficiency in protein alters the osmotic pressure and can cause edema within the body. Patients lose a significant protein through wound drainage. We've talked about the exudate that comes from the wound, white cells and that kind of thing. It also has a lot of protein in it. So when there's a significant amount of that draining out, then the patient's just losing that protein through that drainage. Protein is about 16% nitrogen, and you must have a positive nitrogen balance to heal for the wound, for the wound to heal. So when you have this loss of protein, you're also losing that nitrogen balance and decreasing the ability to heal. So generally, it's 1.25 to 1.5 grams of protein per kilogram of body weight daily is what's required for protein. We see a lot of protein deficiency in older population because most of what they eat, it tends to be for taste, and carbohydrates, especially the sugars, are what we taste the most. So people who are older will maybe eat carbohydrates more than they will protein, and have some protein deficiency. So again, there may be a need to be a nutritional or a dietitian referral if there's a significant loss of protein, because that will delay wound healing. Carbohydrates we get primarily in the form of glucose, and they provide energy for tissue repair and regeneration. Carbohydrates have a protein sparing effect, so meaning that the body burns carbohydrates first. So if the body's burning carbohydrate, has enough carbohydrates to burn, then it won't burn the protein, or won't burn the muscle, won't break down the muscle or the fats. So carbohydrates have a protein. That's how carbohydrates have a protein sparing effect. So generally, we need to have between 30 and 35 kilocalories per kilogram of body weight daily of carbohydrates. Fats are needed. Energy source from carbohydrates are completed. Most are the vitamins that we're going to talk about that are important. Some of them are carried in the fat. Fat also assists with thermoregulation. A lot of times in older people, you see the loss of the fat layer between the skin as they age. You hear older people talking about being cold because of that loss of that fat layer. Additionally, the skin becomes much thinner, and you see more skin tears once there's the loss of that fatty layer. And then free fatty acids are a vital component of cell membranes. So when you're talking about proliferation phase, you have to have the free fatty acids in the body to synthesize the new cells during the proliferation phase. So here's the vitamins we talked about. You have fat soluble and water soluble. A, E, and K are fat soluble, meaning they're stored in the body within fat and the fats. And it is easy if you take too much of this, for it to become toxic, because they do accumulate in fat. They're not flushed through. They are stored in the fat. Whereas water soluble, which is C in your B complex, they're flushed through. They come out in your urine. They're flushed through your body as water moves through your body throughout the day. Vitamin A, or retinol, this is something we've heard about commercially because it maintains a youthful skin. A lot of the creams, commercial skin creams for women, over the counter contain a retinol, and both prescription contain a retinol because it maintains healthy skin and epithelial integrity. It's also required for collagen synthesis, promotes granulation tissue formation, and facilitates epithelialization. So retinol facilitates a turning over of the skin, and again, as they say in the commercials, the youthful appearance. It actually may reverse the inhibitory effects of corticosteroids and may increase the wound tensile strength. You can get retinol in both a topical and a systemic supplementation, so they can put it on topically or also take it systemically. Vitamin C builds and maintains tissue. It helps the body absorb iron. It may help control infections and limit damage effects of free radicals. There is a subclinical deficiency in vitamin C is pretty common. Most people don't get enough daily vitamin C. So this is something that you may see a deficiency in your patient population. Vitamin K is a fat-soluble vitamin. It's essential for blood clotting. A lot of times when people have a blood clotting disorder, they are given vitamin K. In addition, if there's a deficiency, it may lengthen the inflammatory process. or the inflammatory phase, of wound healing. If the patient is on an anticoagulant, however, you do not want to supplement them with vitamin K because, again, they're on an anticoagulant, and if you start supplementing vitamin K, then you can start clotting, or you can reverse the effects of the anticoagulant they're on. This is the reason that a lot of people you'll see who are on anticoagulants such as warfarin, heparin, are not allowed to eat leafy green vegetables, because leafy green vegetables have a lot of vitamin K in them. The B-complex vitamins are one of your water-soluble vitamins. There's 8 of them. They're required for normal immune function and energy metabolism. They also aid in white blood cell function, antibody formation, and resistance to infection. They facilitate fibroblast function and collagen synthesis. They're very important coenzymes. And as I said, they are the B-complex vitamins. You hear about them for, the main thing you hear about them for is energy. But they are important coenzymes in healing. Vitamin E is one of your fat-soluble vitamins. It helps prevent free radical-related cellular damage. It decreases the inflammatory phase of wound healing, enhances immune function, and decreases platelet adhesion. Vitamin E is an important supplement to the skin and to wound healing. So some of the minerals we're going to talk about, the microminerals are iron, zinc, copper, and magnesium. The macro, or the bigger minerals, are the calcium, phosphorus, and selenium. Skin contains about 20% of the body's zinc stores, so there's a large amount of zinc in the skin. It's vital to collagen and protein synthesis, cell proliferation, epithelialization, and normal immune function. It is an antioxidant. In the past, I have known some wound clinics to supplement patients or to suggest supplementation of zinc to increase wound healing. Iron is a component of hemoglobin, as you know. It's required for antibody production and normal immune functioning. It is a cofactor in many enzyme systems, and it is required for collagen and DNA synthesis. If a patient is low on iron or anemic, anemia as we call it, may lead to tissue hypoxia, decreased immune function, decreased cell replication, and decreased wound tensile strength. In someone who is not getting enough iron, often there will be supplemented with an iron supplement. Copper is required for hemoglobin synthesis and iron absorption and transport. It increases the strength of the collagen cross-link. So that's why during the remodeling phase, it's really important that there's enough copper in the diet. Deficiencies may lead to poor wound healing and decreased immune function. Magnesium is a co-founder in over 300 enzyme systems. It's important for bone and protein synthesis. If you have inadequate stores of magnesium, you can have hypertension and vasoconstriction. Deficiencies often found in patients with diabetes, alcoholism, chronic diarrhea, or dehydration. And then calcium is needed for bone formation and remodeling, obviously. But it's also used in the sodium-calcium pump that we know of in muscle contraction, and it's important for fibrosynthesis and important for blood clotting. And also it is a neurotransmitter. Phosphorus is important for bone formation and is needed for normal metabolism. It is also an essential component of many of the enzyme systems. Selenium is also important for normal immune function, and it is a component that's required to make up 30 proteins within the body. So here's a good table to give you some ideas when you're looking at a patient to do a quick nutritional screen, some of the characteristics you're looking for are on the left-hand column. In the middle, you want to ask a little bit about a recent dietary history, some questions about weight loss, how much they're eating in general, how much they understand about what they're eating and nutritional guidelines. And then you want to look at the wound characteristics. Is it slow healing? Is it chronic? Have they had repeated ulcerations, or is there pressure, neuropathic ulcers, or extensive burns? Because all of these are going to require an increased energy uptake, and so therefore an increase. There's going to be increased need for good nutrition. And then finally, on the right hand side, we see some comorbidities, which would also lead you to, or trigger you to think about a nutritional screen or dietitian referral, and those are such as diabetes, cancer, obesity, HIV/AIDS, dysphagia, which is trouble swallowing, gastrointestinal dysfunction, so if there's anything going on with their stomach like ulcers or irritated bowel, anything like that, you'd want to make sure that there's a nutritional screen. If they're an NPO, which means nothing by mouth, then you're going to want to make sure there's a nutritional screen because they're not getting any intake. Or if they're receiving a parenteral nutrition, which is a nutrition they receive through a tube in their stomach, then you want to make sure also that they have a screen for all of the components of good nutrition. So to do a nutritional assessment, you can look at the patient's body mass index and compare it to normal values. If there's any recent changes in body weight, 1% in a week, 5% in a month, 7.5% in 3 months, or 10% in 6 months, you really want to look at getting a nutritional assessment for that patient. And just because a patient is obese, please don't assume that their nutrition is good. A lot of times, obese patients are at risk for a impaired healing just because their nutrition is missing. There's something missing within their nutrition, so they would be candidates for a nutritional assessment as well. So here's a table that gives you an idea of body mass index and whether, depending on what it is, whether they're underweight, normal weight, or obese. And then this table gives you, and I think for the next couple of slides, or you're going to see this table that gives you the nutrient on the left, and then what happens if you see deficiencies, or if there are deficiencies, as on the right. For example, if there's a deficiency of water, or if there's they're dehydrated, you're going to see dry skin, hair, mucous membranes, poor skin turgor, increased heart rate and respirations, orthostatic hypertension, confusion, and sunken eyeballs. If there's a deficiency in protein, you can see dull, dry hair. There's going to be a pallor about them. As we talked about, deficiency in protein can cause edema, peripheral edema, arms and legs. Also can cause pressure ulcers, especially multiple or repeat ulcerations. And if there's a deficiency in carbohydrates or energy, you can see decline in body weight, again a pallor, and extreme poor dentation. With that, you'll see a deficiency in that they'll be emaciated. There'll be epidermal flaking because there's not enough fats to keep the skin supple. There you'll see some fissuring or splitting of the skin and large flakes of dandruff. Vitamin A deficiency can lead to night blindness, difficulty adapting to changes in light intensity, scleral changes in dry eyes, gingivitis in the teeth, pigment changes in the skin, and then very dry skin. Vitamin C, you'll see swollen gums that bleed easily. There'll be a transparent skin quality. You can see weakness and delayed wound healing. And vitamin K can lead to petechiae, which are the little red kind of little red bumps that you see underneath the skin. And a wound will bleed very readily because, again, that clotting factor, there's a deficiency in that clotting factor. B vitamin complex, you can see again pallor or pale eye membranes, hyperpigmentation, redness or swelling of the mouth, mouth sores, purple discoloration of the tongue with a loss of villi, which is the little things that stand up on your tongue, so the tongue becomes more smooth, swollen gums that bleed easily, confusion, muscle cramps, and anemia. With zinc, you'd see a decrease or deficiency of zinc. You'd see a decreased sense of taste, dull, dry, or thinning hair, and then seborrhea-like dryness and redness of the face. Iron deficiency, you're going to see a pallor or yellow discoloration of the skin. There's soft, spoon-shaped nails. Easily fatigued. There's dyspnea and anemia. Copper deficiency, you'll see thinning of the hair, and they may have pigmentation changes. Magnesium, you'll see dehydration and neuromuscular hyperexcitability, and then some confusion. Calcium, you can, in an acute nature, you can see neuromuscular hyperexcitability and dysrhythmias. Especially calcium is especially important when we talk about the dysrhythmias. We're talking about heart dysrhythmias. So calcium, if they're severely deficient, can be life-threatening because it can cause the heart to change its pattern, or have a dysrhythmia, which again could cause the heart to stop. You can also see skeletal disformities such as a kyphoscoliosis, idiopathic and compression fractures, as we see in osteoporosis, bone pain, dry scaling, skin and hair, and brittle nails. Phosphorus, you'll see some skeletal deformities and idiopathic fractures because, again, it's such a large component of the bone, the makeup of bone, and then bone pain. And in selenium, you'll see a decreased ability to fight infection, muscle pain, and muscle wasting. So let's talk a little bit about laboratory testing. Creatinine is a measure of kidney function and protein status. Often when they do a creatinine level, you can see if there's a decrease in creatinine level, you're going to suspect some malnutrition. Normal levels are between 0.8 and 1.5 milligram per deciliter. Serum albumin is a plasma protein that's produced by the liver. The normal levels are at least 3.5 milligrams per deciliter. Low levels you would see with a pressure ulcer severity. So the more severe the pressure ulcer, the lower levels of serum albumin you'll see. Low levels can also lead to edema, and if there's dehydration, you'll see an increase in serum albumin. Prealbumin is the transport protein that you see in the body. Normal values are 16 to 40 milligrams per deciliter. Mortality risk increases as the levels drop. So as you see this going down, it really increases their risk of death. It has a very short half-life. So if someone has had changes in their nutritional status, the prealbumin doesn't stay around long in the body. It will drop pretty rapidly if there's a change in nutritional status. Serum transferrin is a sensitive indicator of protein status within the blood. Levels less than 170 milligrams per deciliter indicate malnutrition. So this one is another good, when they're doing laboratory testing of the blood, it's good to look at this serum transferrin to see what's going on with their nutritional status. Blood urea nitrogen is a byproduct of protein metabolism. It is excreted by the kidney, so it's an indicator of renal function. Normal levels are between 5 and 25 milligrams per deciliter. Elevated levels are associated with decreased wound healing because it means that the kidneys aren't filtering the toxins out of the blood. So you're not going to see you're going to see wound healing slow down significantly with elevated levels. Total lymphocyte count is an indirect measure of nutritional status and immune function. Normal levels are greater than 1800. Decreased TLC is associated with delayed wound healing and increased mortality. You're looking at the total number of white blood cells that are flowing throughout the body with this count. Blood glucose normal levels are between 7 and 110 milligrams per deciliter. Increased levels are associated with the risk of ulceration and impaired wound healing, because increased levels we would call diabetes. So blood glucose is important to know what it is at any given time. So some of the main causes of malnutrition are a lack of knowledge about nutrition, poverty, so the inability to get the healthy foods that are needed, or health problems. I've talked about a few of the health problems, such as maybe they're NPO, nothing by mouth, or they're having some reason that they can't eat, so such as someone who is comatose or sick, or sleeping more. Any of those things can cause malnutrition, because it's preventing them from taking in the calories and the nutrition. Clinicians should instruct patients and caregivers on proper nutritional guidelines. Generally, you want to take in 30 to 35 calories per kilogram of body weight, and 1 1/4, and we've already said this, 1 1/4 or 1.5 grams of protein per kilogram of body weight. If the patient is taking in, or appears to be taking in, the right amount of nutrition, but they are not improving, you always want to consult a registered dietitian. So here's a little flow sheet that can kind of give you some ideas about what you need to do, where you need to go with the nutritional intervention. So if they're malnourished, you either need to educate them, or you need to talk about, is their stomach actually functioning? If their stomach's not functioning, you would do TPN, which is total parenteral nutrition, which is what I was talking about, where they get their nutrition either through a tube or through an IV. If their gut is functioning, but they're malnourished, you just need to supplement so that they are no longer malnourished. If they're at risk for malnutrition, again, you want to educate, but then you want to see if you also want to see if the dietary intake is sufficient. If it's not, you want to encourage intake and assist with feeding as needed. It may be like in a patient who has dementia or forgetfulness. They may forget to eat. They don't have that need to eat. So they actually have to have be fed, had timed feedings and timed snacks and that kind of thing to encourage them to eat and keep the weight on. If their dietary intake is sufficient, you just want to monitor them and make sure that they continue to have sufficient intake. So pressure ulceration or pressure formation is associated with a protein calorie deficiency. Again, a lot of times with someone who is very sick, such as someone with a spinal cord injury or a head injury, or someone who is elderly and bedbound, you're going to see a pressure ulcer formation because they're not moving, and they're not getting the nutrition that they need to keep the skin healthy. Neuropathic ulcerations are more prevalent in patients with poor glycemic control. So if you see someone who has the high blood sugars, as we talked about, greater than 70 or greater than 110, then you're going to see somebody who probably has a neuropathic ulcer. With burns, you do increase the metabolic rate, so they're going to require more calories. So they have to be on a high calorie, high protein, high carbohydrate, and low fat diet. There's going to need to be supplementation of a multivitamin, A and C, and zinc. And because of the amount of calories that are required for a burn. Anyone who has a large burn actually may have to get tube feedings or TPN feedings just to keep up on that calorie requirement. Let's talk a little bit about patient adherence. So compliance means that you as a clinician are directing the patient on what to do. It's a one-way interaction. You've given them instructions and they're compliant with it. Whereas adherence means that the patient chooses to follow the suggested guidelines. So if the patient is adhering to what you suggested, that means that they're doing it on their own. And some of the reasons that patients fail to follow clinical recommendations are, having to do with education, having to do with some of their characteristics, which we're going to talk about in a minute. So, non-adherence may be unintentional. It may be, so in other words, if the patient doesn't truly understand the importance of adhering to your instructions, then they may say, oh, it's not that important, and they may be non-adherent. They may misunderstand the directions or the guidelines that you're giving them. They may forget them, or they may say, I just don't want to do it because it's too hard. So it may be intentional. So some of the factors that affect adherence relate to the patient, meaning, again, does the patient understand? Did they hear you correctly? Did they understand the different components of what the guidelines are? Is it something they can do? Can they do it on their own? Do they require assistance to do it? Is it something that requires them to do to change a lifestyle choice, like maybe they're a smoker and you're asking that they not smoke so that they heal. And then the last one is clinician. The clinician's attitude on adherence is really important, or I'm sorry, clinician's attitude on the patient's compliance is really important. So you as a clinician, if you see signs that they're not being adherent, you need to address those. To just look the other way or not pay attention to what's going on with the patient is going to not promote adherence. So if you see signs, the book gives an example, and I've told you an example of a patient that I've seen where they would be wrapped and they'd come back in and their dressings would be dirty. So, why are you wearing these dressings? Why are you running out in the yard with these dressings on? Or why are these dressings getting dirty? So when you see things like that, you really have to address it with the patient, because if you don't, then you're not going to get the adherence. If you look the other way or just ignore it, then you're not going to get the adherence from the patient that's really needed for them to heal. All right, so patient characteristics, some of the patient characteristics, if you emphasize past experience, does not dictate future outcomes, meaning that, so let's say a patient has a neuropathic ulcer. I think the book gives you an example of a neuropathic, they're diabetic and they had an ulcer on their, the head of the first metatarsal, and it healed in a couple of months. They came to see PT and it's healed in a couple of months. Well, they may think that same thing will happen this time, that they'll have that quick healing rate even if they didn't do what they needed to do. And as we know, that's not always the case. So additional wounds may heal slower for different reasons. You also want to encourage self-confidence and self-efficacy, meaning that the patient needs to understand that they have to it must be important for them to heal, or it must be important for them to be adherent so that they do heal. And you also want to encourage caregiver involvement. So if the patient seems to wane in what they're doing and how efficient they are in what they're doing, then you want to make sure the caregiver understands that they need to be encouraging that. And then you also want to set mutually agreed upon low risk solutions, meaning if the patient can't adhere for whatever reason, then you want to talk about, okay, so how do we make it easier for you to adhere? Because they may not be adhering because it's too hard for them. So you want to say, okay, how can we make this easier? How can we make this so that you can do it? You want to emphasize a cooperative effort, meaning that you want to say to the patient, when you're treating them, you help them to understand that you can't do this by yourself. They have to be a part of their own care in order for them to heal effectively. So you want to define role expectations, what you're going to do, what they need to do. And you want to provide the knowledge. You want to make sure they understand every component of the healing. So you want to make sure that they understand why it's important for them to be adherent. If they don't understand it, then they can't necessarily make the decisions that they need to make. And you also want to let them know what happens if they don't adhere to your suggestions. What are the consequences of non-healing, or what are the consequences of not only non-healing, but what are the consequences of the wound getting worse. So you want to inform them of those as well. As far as task characteristics, you want to identify and remove any barriers, such as their physical inability to perform the task you're asking them to do, or the guidelines, or maybe if they don't have supplies, you want to make sure they have the supplies. You want to communicate what you expect them, how you expect them to behave, and provide very clear instructions. Have them demonstrate it so they understand what you're saying, and educate them on the importance of doing the task that you've given them. And you also want to emphasize the short and long-term effects of them performing the tasks you've given them. So clinician characteristics, the main thing is the patients with poor relationships with their clinicians are less likely to be adherent. So you want to make sure they understand that you are concerned about them. You want to listen to their concerns. You want to reinforce their behaviors, and you want to really talk to them about how they have to be engaged as well as you're going to be engaged, so together you can meet the goals that have been set for this patient. So wound management is very much a team approach. We've talked about this in this particular chapter. We've talked about the importance of a dietitian and nutritional assessment. We've also talked about before, nursing does a lot of wound care. A lot of wound management is with the nurses. So if you're called in to assist in wound management, you're going to have to make sure that you're on the same page with the nurses, and make sure any goals, like let's say it's a pressure ulcer and you've got positioning goals, you're going to have to make sure they understand that and they're on board with it. So formal communication is essential. There needs to be daily rounds, a flow sheet or a dry erase board, and then weekly conferences. In some cases, there'll be weekly conferences with the patient, family, and the medical team, so you can all be on the same wavelength and have that good communication.